Dr. B here with our series on demystifying the DSM. The last two were bipolar 1 and bipolar 2, and now I'm just going to kind of sum up the other bipolar type diagnoses. I don't personally study the DSM, and so it's kind of funny that I'm doing this demystifying the DSM, because it's very concrete in like putting people or diagnoses in specific boxes. I personally study Dr. Stahl in his symptoms and receptors, and any professionals out there listening to this, that's who I recommend that you study from, okay? These videos are really more for our clients to understand these diagnoses. And when I'm talking to my clients, I'm very specific. Don't own this, right? This is just a cluster of symptoms. We can work with this, the mentally strong method and the cognitive behavioral approach to kind of get your thinking and your choices in line with what you want. And if there is a neurobiology symptoms and receptor, we can treat that with medication. But it's important because I often have students and clients that are referring to the DSM. And bipolar is one of those diagnoses that a lot of people have come to me with, and I've teased it out, and maybe it's really PTSD with reactive attachment, or it's really more of an anxiety and depressive disorder. But it's not so important. But what's more important is those symptoms and receptors. And so I'm going to kind of quickly go through some of these other bipolar types. Cyclothymia is the next one here in the DSM. And it's basically a milder bipolar 2, right? So you don't really meet criteria for hypomania, don't really meet criteria for major depressive disorder, but you still have these pretty, significant fluctuations in mood. And but I would challenge that maybe that we can do that with therapy, or is there like a borderline personality or some other personality disorder contributing to that fluctuation? So that's one of the differential diagnoses with cyclothymia. The other thing that we often see is substance use, and substance use can often look like bipolar, but it can also mask true bipolar. So really, when there's substance abuse going on, the number one goal is sobriety. And there's actually several mental health clinics that won't treat someone's mental illness until they have become sober. I actually will treat the mental illness while I'm trying to encourage sobriety, because I think it would be very difficult if I'm severely depressed to stop using my substance if I can't get treatment for my depression, right? So there's two schools of thought on that, but substance abuse can always complicate the diagnosis, and often can look like bipolar. Also, you can have a fluctuating mood disorder secondary to a medical condition. And so the first thing I tell people, especially if they're coming in at 50 years or older with their first significant mood disorder symptoms, I'm really looking hard at, is there a medical reason for this? Because most mental health conditions start in childhood, teens, 20s, rarely early 30s. After that, if there's no mental health history and then someone has significant problems, let's look really closely at medication that they've been prescribed. Steroids is a big culprit. I've had several people who have post-steroid mood disorder that looks like bipolar. And sometimes we do have to treat that for a period of time. And sometimes it can take 6 months to a year post-steroid use to kind of feel stable out from that. So anytime someone is not presenting, that is presenting with some other medical conditions, look at the medications that they're on, as well as any kind of neurological or inflammatory conditions can actually present as mood problems. And then we have the bucket of unspecified bipolar that, and I actually use this diagnosis frequently because I don't know the client well enough to say for sure it's bipolar 1 or bipolar 2. I'm actually, possibly looking at a prodromal schizophrenia type thing. And so oftentimes when you see this, kind of bipolar unspecified, is we're saying that there is a significant mood disorder, but we haven't been able to really pinpoint it yet. And that's there in the DSM. And then it just kind of goes through in trying to show you all these little boxes of additional modifiers on that bipolar with psychotic features, bipolar with melancholic features, bipolar with catatonic features. And we like to get to that point, but I can tell you typically in the first 3 to 6 months, I can't be that specific. And oftentimes it doesn't matter to be that specific because mood disorders can change, the presentation can change, and there's, unfortunately insurance companies tell us, these are the 10 diagnoses that we will reimburse for treatment, and so we kind of stay within those. So oftentimes we don't put a lot of specifics on there because it's not super important for treatment and for long-term prognosis. So that is the bipolar series.